Well, welcome. We're going to give you a lecture on visually induced trigeminal dysphoria, and it's likely what's causing a lot of people to have headaches, eye strain, and dry eye problems. My name is Dr. Jeff Krall, and I'm an optometrist in Mitchell, South Dakota. Spent a lot of years trying to understand why people are symptomatic, and we also have Dr. Carol Nelson. She's a neurologist with Neurology Associates in Sioux Falls, South Dakota. And I'm going to let Dr. Nelson explain how we met and how we got started. So Dr. Nelson, will you give them a little background of how we got connected?
Sure. So Dr. Krall and I met in about 2011 when we started having a lot of patients in common. We practice about an hour down the road from each other. And so we started to have patients in common with headaches. And one of the patients that I was examining had some glasses on, and when I asked her to take them off so I could take a look at her eye movements, she told me that they were her migraine glasses. So being a skeptical neurologist, I was wondering what these glasses were that I had not heard of. And the patient told me there were some prisms in the lenses. So I thought, well, I'm going to check with Dr. Krall and make sure, the eyes are aligned fine. I was actually wondering whether I needed to get an MRI of the brain to check for some sort of brainstem pathology. And so I sent a letter to Jeff asking what these were and what was going on. And he was nice enough to give me a call back and kind of explain what his family had really discovered and give me a brief overview of what he was doing and some of the results he was having. And it intrigued me enough that we started meeting together to talk about this particular discovery that he had. And we started doing a study together, which we'll talk about later on here.
So what I'd like to do is we'd like to give you a little insight of what we're going to go on some goals. But first of all, as full disclosure, I am a paid consultant for iBrain Medical, and so is Dr. Nelson. So discussion goals, we want to go over, digitally evoked, digital vision syndrome is a big problem in our community. There's a lot of people today that it's impacted their lives in a negative way. So we're going to discuss some research that's been conducted between neurology and optometry. Those are clinical studies that Dr. Nelson and I were involved with. We're going to discuss and help you understand the mechanism why these people are having headaches and dry eye, neck tension. And we're also going to discuss the best treatment modalities and practices and applications in order to make these people less symptomatic. And I can just tell you on a personal note, it's taken a long time to try to put the pieces of the puzzle together. I'll give you a little bit of history. My great-grandfather, grandfather, and father were all in the eye care business. My great-grandfather graduated in 1900 from the School of Ophthalmology and Otology. It took him 6 months to get those 2 degrees. And you can't see it obviously very well on the slide, but that first slide that you see, there's a postcard that says you better get your eyes checked. It may be the source of your headaches, and that was printed back in 1910. But I graduated in 1988, and my beginning in optometry started in a lesson in humility. You see, my father understood that your eyes, the way they work together, has a lot to do with your symptoms. But I wasn't quite up to speed when I got out of school. And an old gruff farmer showed up one day in our clinic. I joined the family practice, and he was one of these, pretty charismatic, pretty noisy guys. And he come to the front counter and he slammed his glasses down and he said, "I can't see out of these. They give me headaches and my eyes burn." And he says, "I don't want to see that young kid, Jeff. I want to see the old guy, Dr. Charles, that knows what he's doing." And as a new optometrist out of school, all my patients that I was going to see in the waiting room heard this, and all the staff heard it. And if I could have crawled under my desk at that time, I sure would have done so. But my father, being the great instructor, said, "Jeff, there's a device that I use to help with this, and it was called the Turville Infinity Balance. And this is something that was developed in the 30s. And I was quite certain when I got out of school that I had no interest in using any such device. But I did learn a lot of valuable lessons of what was really happening with that device, and we'll talk about that later. From that point, it really spurred my interest, and I started to educate myself of why these people are symptomatic. And I think I read every piece of literature you could find on convergence insufficiency and all the studies that were done, all the way from Duke Elder to when Essler printed their book on Eyestrain. And I started actually manufacturing lenses in our own clinic and actually bending lenses in the salt pan, inducing some prism. And I started giving people multiple pair of glasses for distance and near, and I would change the amount of alignment that I would give these patients. And I quickly discovered from what these patients told me that if I could change the alignment of their eyes in both locations, distance and near, I could resolve their symptoms. And from that point, we developed a lens that had contoured prism. And we took that knowledge after we started producing lenses to Dr. Paul Karpecki's office. He showed up with I went to his clinic, and he lined up a bunch of these dry eye patients that he just could not resolve their symptoms. And we made a significant impact on those patients. From there, we did a clinical study with Illinois College of Optometry, developed testing equipment, did a clinical study with Dr. Nelson, and she'll share that with you. And from the results from the study that were so impactful in her neurology office, we opened a headache center in Sioux Falls, South Dakota. And that led to increased studies of the impact of trigeminal dysphoria on computer vision syndrome. And so we've learned a lot, and we know we have a big problem out there today. 65% of Americans indicate they have a symptom of digital vision or eye strain. Yet amazingly, only 10% of these people report their symptoms. And that's a little bit, there's quite a disconnect, and it's a little bit sometimes hard to believe, but it's very rarely that someone shows up in your office and says, hey, my neck and shoulders and back hurt, can you help me with that? They assume that their stiff neck and their headache in the back of their head and their sore shoulders is related to their posture, or they need to see their chiropractor. But I want to assure you that very often that these symptoms are related to how their eyes are working together. And you see, this has been documented and talked about for a lot of years, back in the 1800s, and we called it at the beginning asthenopia. We still do. We then switched and called it convergence insufficiency. We got more sophisticated with fixation disparity, and then in the 2000s, we called it computer vision syndrome, digital vision syndrome. But really, it's what's happening is people have trigeminal dysphoria, and we're going to explain that here for you today. So but the American Optometric definition of computer vision syndrome or digital vision syndrome is that patients have discomfort after working 2 or more hours in front of a digital screen. And there's a lot of perceived causes of the problem. Current perception in the marketplace is that it's poor lighting, glare from the screen, improper viewing distance, or their posture is causing these symptoms. And the current solution is tell them to blink more in artificial tears. We do the 20-20-20 rule. We look at 20 feet, and then we use, to try to relax their eyes, we use anti-glare lenses, and we use blue light protection. But I can tell you from a lot of experience, that's not necessarily making many of these people's symptoms go away. So, these problems really predate the digital demand. People back in the 1900s, obviously, that were doing a lot of near work complained of a lot of the same things, although the reason this problem has become larger is there's a big demand or a big change in how we view things today. And there's a dramatic shift, obviously, in our society. Every young man and woman that walk into my office down to 7, 8, 9 years old are holding a digital device in their hand. And obviously, even young children that are born, after they're born at 2, 3, and 4 years old, are very often holding a digital device, trying to learn what to see with. And it's really hard for me to believe, but they tell me, and this is not my research, obviously, but there are more mobile cellular subscriptions in the world than there are people to use them. And there's been an explosion of these devices over the last few years. So the numbers are really telling. 65% of Americans indicate they have symptoms of digital eye strain. Yet again, only 10% of these people report their symptoms to the doctor, and that's according to the American Council of Vision. And so what we did is we went out and we said, hey, we want to really try to discern if we can elicit these same responses from patients today as others have found. So we went in and we gave them a very simple questionnaire to fill out. Do you have neck, shoulder, and back pain, eye strain, headaches, dry eyes, and dizziness? Not dizziness like the room is spinning, but people often complain that if they turn quickly, they feel like they're a little dizzy or a little lightheaded. And then also we asked them if they had sensitivity to light and if they had discomfort using their computer and near devices. And it was quite a large study collected from 21 different sites, different offices around the country. We saw nearly 17,000 people. And we we found that more than 50% of these people, number one, complained of neck, shoulder, and back pain. And along with the eye strain, another 30% of these people had headaches, discomfort at the computer, and they complained very, very often of having very, very dry eyes. And the dryness, if you ask them, is not a dryness necessarily of an ocular surface type dryness, like I have something in my eye. They often complain that their eyes will feel gritty or burned. And that led us to understanding the mechanism is really trigeminal nerve pain related to how our eyes are working together. And I'm going to let Dr. Nelson go through this next for us. Dr. Nelson.
So I'm just going to give a little background first. I'm a general neurologist, but I have a special interest in headache. So my practice has kind of morphed over time to being about 80% headache patients. So the majority of my day is spent seeing headache patients. So what I wanted to do first is kind of make sure we're all on the same page as far as what the different headache types are that we're talking about, with just a real brief summary of some of the more typical headache types. So the first is the migraine with and without aura. So a typical migraine is a unilateral throbbing, nausea, vomiting, light sensitive, sound sensitive headache that's worse with activity. It tends to be severe. And if untreated, it tends to last about 6 to 8 hours, but it can actually last up to 72. Now, an important thing on this first slide about the migraine with aura is they don't have to have all of those things to qualify as a migraine. So don't get hung up on whether it's unilateral or bilateral necessarily if it's fulfilling several of the other criteria. The migraine with aura is the same as the migraine without aura, but it has some sort of reversible neurologic symptom. It has to be reversible, typically lasting about 20 to 30 minutes, but they can last up to a couple of hours. If they last over a couple of hours, I start to get a little bit nervous and feel like we're going to need some neuroimaging to make sure nothing else is going on, just to rule out any other organic pathology. So the migraine with aura, which is what it's called now. It used to be called ocular migraine or ophthalmic migraine. We don't use those terms anymore. However, I think anybody would know what you're referring to. But the correct terminology at this time is migraine with aura. It tends to be either visual, like a scotoma or a scintillating scotoma or fortification phenomena. I think a lot of the things that you are all going to be seeing. It can also cause numbness. Now, sometimes that numbness will be in your fingers on both hands, and that's not necessarily an aura. That's something that just kind of comes along with a headache quite frequently. But if it's unilateral on either side, then it's potentially an aura. There's also an aura with unilateral weakness. That's a very specific headache type called a hemiplegic migraine. And those are really important to identify because the workup is a bit more intense because it looks like a stroke, and the triptans are contraindicated. So like sumatriptan or rizatriptan, that category of medication is contraindicated because it increases the risk of stroke when they have that headache type. So that's a very specific headache type. And some people will get dysphasia or difficulty speaking as an aura. That's a really uncommon one, but we see that sometimes. Now, a really common headache is tension type headaches. The majority of the population has probably had this at some time or other. It tends to be a bilateral squeezing headache as opposed to a unilateral throbbing. They don't usually get nausea and vomiting. I've seen some nausea on occasion with it, particularly if it's severe or long lasting, but they actually shouldn't have vomiting. And they don't tend to be light or sound sensitive. They can get better with activity. So if these people get distracted or if they go for a nice walk or a run or exercise, it can get better. And these headaches tend to be more in the more mild, sometimes up to moderate, but typically just mild. A really common headache type now is medication overuse headaches. And these used to be called withdrawal headaches, like a caffeine withdrawal headache. They changed it to rebound headache, and then now they call it medication overuse headache. They changed that terminology so that the patient knows what they're doing, that they're taking their medications, their symptomatic medications too frequently and therefore causing the headache. And that headache is kind of a nondescript headache. It's sort of a dull headache, a pressure, a discomfort. A lot of my patients will say it's just there. Like they can't even really come up with a term to describe it. It's very nondescript, but it's not throbbing like a migraine. There's no nausea, vomiting, light sensitive, sound sensitive, no change with activity. And they tend to be mild and they last through the whole day. Now, the one thing with medication overuse headaches is they tend to follow the half-life of a drug. Like, for example, if somebody's taking Excedrin, which is a really common one, but a really common one is also acetaminophen or Tylenol, which is, of course, in Excedrin as well. But the headache will follow the half-life of the drug. So the headache can get a little bit better. And then in 4 hours, for example, for the Tylenol, it's going to wear off and the headache is going to come back. So you kind of go through the day going, sort of a waxing, waning pattern of the headache. And then they sleep through the night and don't take the medication. And so they wake up with a headache. So that actually part of the medication overuse headache is really important, that they tend to wake up with a headache. Now, to differentiate that from trigeminal dysphoria, which is what we're talking about today, that headache type tends to be at the back of the head, a lot of neck pain with it. It can radiate up to behind your eyes. It tends to be a constant pressure or an ache. Some people will describe it as a pulling, like an uncomfortable pulling sensation. They tend to get dry eyes, fatigue, light sensitive, particularly with headlights at night, and they're worse with reading and working on the computer. Now, the reason I was pointing out that with medication overuse headaches, that they tend to wake up with it, the trigeminal dysphoria, they don't tend to wake up with it. It tends to come on after they start to use their eyes, once they log into the computer or start to read or start to use their eyes, and then that comes on. So those two headache types kind of are described by the patient somewhat similarly. So sometimes that's the way I differentiate between the two, is whether they're waking up with it or not. So I want to back up a little bit and just kind of explain the pathophysiology of migraine as we know it to this time. It's changed over the last few years, what we think the pathophysiology is. And of course, it's important to understand that in order to come up with, well, in my situation, most frequently medications, and what you're targeting to treat. So you've got to understand what's wrong in order to treat it, which is actually a lot of what we are spending time doing with the trigeminal dysphoria as well. So you'll all recall the trigeminal ganglion there, and the trigeminal nerve has 3 branches. The branch that we're most interested in at this time is the ophthalmic branch. So the first branch, or the V1 branch of the trigeminal nerve. And that one, of course, supplies the meninges around that front part of your head and around the eye. And we don't know exactly why, but that nerve tends to be somewhat irritable. So I describe that like a campfire. That's just the coals are sort of smoldering, sort of waiting to fire up. So it's kind of irritable, waiting to be irritated or fired up or inflamed. And that, we think that's probably the irritability probably is set based upon your family history. So if your mother and grandmother had headaches, your nerve, the V1 branch particularly, is just more irritable and more likely to fire or flare. So if you follow that V1 branch into the brainstem where it's originating from, the trigeminal nucleus caudalis that goes through there, which is the light green there, you see that goes basically through the majority of the brainstem. It's the longest nucleus in the brainstem. And you see that it dips way down. It actually goes down further than this drawing shows you, but goes down to the first and second cervical nerve roots, which of course go to the area of the neck. And so when that trigeminal nucleus caudalis is irritated, it actually irritates the nerves going into the neck, which is important when we think about how often migraines and also trigeminal dysphoria have neck pain as part of the headache syndrome. And that can come before the headache, during the headache, after the headache, any of those. So what happens is this nerve root, or rather this first branch of the trigeminal nerve becomes irritated. It irritates irritates the trigeminal nucleus caudalis, which then causes irritation along the back of the skull as well. As that really gets going, it changes all the chemicals in the brain. So the entire brain becomes involved, all the neurotransmitters. And that's when people get light sensitive, sound sensitive, nausea, vomiting, difficulty thinking, irritability, all the other things that come along with the headache. So we're going to go to the next slide here, which we are going to show a brief video of the mechanism of trigeminal dysphoria.